Okay, let's dive into our roadmap for today. First up, managing BPH medical approaches. Then, surgical fixes for BPH. Third, prostate cancer, risk factors and spread. Fourth, decoding the Gleason score. And finally, treating prostate cancer.
Starting right off with Section 1, Managing BPH, Medical Approaches. So, let's kick things off with the first half of our tale, managing that benign yet highly disruptive prostate enlargement, and we start right at the pharmacy. To manage BPH medically, you really have to understand the rule of contrast, because you're essentially fighting a war on two different fronts. First, there's the dynamic component, that's the smooth muscle tone. You attack this with selective alpha-1A blockers, like tamsulosin. This is going to give your patient a really fast onset of action, relaxing that muscle in just a matter of days. But then you've got the static component, the actual physical hyperplasia of the gland itself. For this, you bring in 5-alpha reductase inhibitors like finasteride. Now, these are incredibly slow-acting. We're talking weeks to months here. Why? Because they work by stunting the conversion of testosterone into its active form, which eventually shrinks the prostate volume by about 20 to 30% over 6 months. Since they target entirely different things, combining these two is absolutely the ultimate medical strategy. Oh, and here's a crucial real-world caveat for you. Finasteride actually halves a patient's PSA levels, so whatever number you're looking at on their lab results, you literally have to multiply it by 2 to get the true value.
Moving right along to Section 2, Surgical Fixes for BPH. So what happens when medications just aren't cutting it? Well, you don't just jump straight to surgery for every enlarged prostate. You have to wait for the red flags. We're talking things like upper urinary tract involvement, think hydronephrosis, or outright failure to respond to those meds we just talked about. You also look out for acute or chronic urinary retention, multiple UTIs, or a flow rate dropping way down below 10 milliliters per second. But you know, the one indication I'll never forget is a single episode of gross hematuria. I actually saw this play out in real life when my own grandfather, who was fully active at 92 years old by the way, developed gross hematuria. It immediately confirmed his BPH had progressed to the point where surgery wasn't just an option anymore, it was mandatory.
And the gold standard surgery he ended up getting? A TURP, transurethral resection of the prostate. Honestly, this procedure is a total game changer, yielding greater than a 75% improvement in symptoms for most patients. The mechanics of it are fascinating too. A resectoscope is passed right through the urethra, literally cutting away these blocking chips of prostate tissue to open up the lumen. The surgeon uses a very strict anatomical landmark called the verumen. They absolutely cannot cut distal to this bulge, or they risk destroying the external sphincter and causing outright permanent incontinence. But even with a flawless surgery, there's a major structural trade-off you have to know about. Because the bladder neck is intentionally carved out and rendered incompetent, the most common complication, affecting 60 to 75% of patients, is retrograde ejaculation.
Now, what's really interesting about this slide is this single massive number right here, 1 liter. That is the massive, potentially lethal fluid shift that can occur during a standard 50-minute TURP procedure.
So, how does that happen? Well, to keep the visual field clear of blood during a TURP, surgeons have to pump irrigating fluids into the urethra. But since the venous beds are cut wide open, water moves straight from the hypotonic urethra directly into the isotonic vascular system at roughly 20 milliliters per minute. Run that over a 50-minute surgery, and you've just pumped a whole liter of water directly into your patient's bloodstream. This massively expands their blood volume and radically dilutes their sodium, causing what we call TURP syndrome, or dilutional hyponatremia. The patient might wake up with an altered sensorium, nausea, a terrible headache. If their sodium drops below 120, you absolutely must correct it with 3% hypertonic saline. But here is the critical why behind this management plan. You have to correct it slowly. You are strictly limited to a maximum of 8 milliequivalents per liter per day. If you panic and move too fast, you trigger central pontine myelinosis, which is a disastrous and entirely irreversible destruction of the brainstem. Definitely not something you want to mess with.
All right, on to Section 3, Prostate Cancer, Risk Factors and Spread.
Now that we've cleared the mechanical blockage of BPH, let's pivot to a much more insidious threat. Prostate cancer is an adenocarcinoma, and it's intimately tied to age and genetics. Get this. If a male reaches the age of 90, there's a staggering 90% chance he's harboring foci of prostate cancer. It's almost guaranteed. Other high-yield risk factors include high testosterone, being of African American descent, carrying the BRCA2 gene mutation, and, most commonly, the GSTP1 gene mutation. Because it is just so incredibly prevalent, screening starts at age 50 using a digital rectal exam and a PSA test. If those flag is suspicious in any way, the gold standard for confirmation is a transrectal ultrasound-guided true-cut biopsy, where you take a minimum of 12 cores to be sure.
Now, if this cancer manages to escape the prostate, it doesn't just go anywhere. It follows a very specific pathway. Locally, it invades the seminal vesicles or the rectum. Lymphatically, it hits the obturator lymph nodes first. That's a fantastic piece of urological trivia for you. But it's the distant spread that's truly defining here. It absolutely loves to travel to the bones, specifically the lumbar vertebrae. And it does this by riding right up the valveless veins of Batten's plexus. And here is a crucial distinction. While something like breast cancer typically causes bone-destroying osteolytic lesions, prostate cancer causes bone-building, yet structurally weak osteoblastic deposits. On a bone scan, these show up as very distinct dark black patches.
Which brings us to Section 4, decoding the Gleason score.
Okay, so you've done the biopsy. How do pathologists actually grade the severity of this highly heterogeneous cancer? We use what is arguably the most critical scoring system in all of urology, the Gleason score. Because prostate cancer is basically never uniform, pathologists look for the most commonly occurring gland formation and then the second most commonly occurring gland formation. They grade each one from 1, meaning well differentiated, all the way to 5, which is poorly differentiated, and then they add them together. And this slide brilliantly illustrates exactly why the order matters. Just look at a total score of 7. A 3 plus 4 means the dominant tissue is grade 3. We classify that as intermediate favorable. But flip it to a 4 plus 3, meaning the worse grade 4 tissue is now dominant. That entirely shifts the prognosis to intermediate unfavorable.
But listen, while the Gleason score is absolutely vital, the single most important prognostic factor for prostate cancer is actually the stage of the disease. That's exactly why clinicians rely so heavily on the Parton tables and the D'Amico score. By taking the Gleason score, adding in the exact PSA levels, and combining them with the tumor stage, these predictive tables act like clinical gold, letting us calculate a highly accurate risk of cancer recurrence.
Finally, Section 5, treating prostate cancer.
All right, let's shift into our categorized battle plans. For early-stage disease, meaning it's confined entirely to the prostate, we divide patients down 2 very distinct paths. For older patients with a life expectancy of less than 10 years and a favorable tumor grade, honestly, we just observe. And to be clear, active surveillance isn't giving up. It's a calculated recognition that these specific early tumors progress so incredibly slowly that the patient will likely pass away from other natural causes long before the cancer ever becomes a real threat. We're sparing them unnecessary surgical morbidity. However, for younger, fit patients with aggressive grades, we go on the attack. We utilize a robot-assisted laparoscopic radical prostatectomy, where we carefully preserve the cavernous nerves in the capsule to save erectile function, all while entirely removing the gland, the seminal vesicles, and local lymph nodes.
When the cancer is locally advanced, pushing out into the seminal vesicles or local tissues, the surgical scalpel usually takes a backseat to radiation and chemical warfare. The first line of defense is aggressive radiotherapy, delivering up to 86 grays. And here's a quick clinical pearl, brachytherapy. Urologists can actually implant radioactive seeds like iodine-125 or palladium-103 directly into the prostate to shrink the localized disease from the inside out. Once the radiation does its job, we often layer on androgen deprivation therapy to just starve any residual cells, only ever resorting to a radical prostatectomy if stubborn disease remains. Now, if the cancer has metastasized, we have to cut off its fuel supply globally. Prostate cancer feeds on testosterone, right? So we deploy medical castration using LHRH analogs like Zoladex. But here is the physiological chess match you have to anticipate. When you give these analogs, the body's negative feedback loop initially completely panics, causing a massive, transient spike in testosterone for the first 10 days. If you aren't ready for it, this causes a dangerous tumor flare. To outsmart the body, you must co-administer anti-androgens, like flutamide, right from day 1. This blocks the receptors and safely navigates that spike until the testosterone levels finally crash.
But you know, cancer is remarkably adaptable. After a few years, these tumors can actually outsmart the hormonal starvation entirely and become hormone resistant. When that happens, we unleash the advanced countermeasures. We can hit them with chemotherapy like cabazitaxel. We can use incredible immunotherapy like sipuleucosol T, which is this highly customized T-cell vaccine engineered right from a CD54 extract. And for those deeply painful, hormone-resistant bone metastases, we use targeted radiopharmaceuticals like radium-223, which literally hunts down the bone lesions and bombards them locally with destructive alpha rays. It's amazing stuff.
Throughout all of this, we track the success of these therapies by keeping a very close eye on the PSA levels. A rising PSA is the ultimate, undeniable early warning system that the cancer is trying to stage a comeback. Which leaves us with a pretty profound question to wrap up on. As our screening gets more precise and our molecular understanding deepens every day, what emerging breakthroughs will finally allow us to stop prostate cancer entirely in its tracks, long before it ever requires castration or radioactive seeds? It's a dense medical labyrinth for sure, but understanding these pathways is the absolute first step to beating it. Thanks for diving into this explainer with me today, and keep that focus sharp.